Everyone is smiling and ready to eat, so this is good. This is good. Well, good afternoon. Welcome to the National Minority Quality Forum's 12th Annual Leadership Summit on Health Disparities, and thank you for attending today's Biodiversity Health Policy Luncheon. My name is Brandon Webb. I'm the Legislative Director to Congresswoman Robin Kelly of Illinois, this year's Congressional Black Caucus Health Braintrust Chair. And I have the privilege of being your moderator this afternoon, so thank you for that. Since Congressman Louis Stokes wisely and expertly took the helm of the Braintrust and passed it on to the gifted hands of the Honorable Dr. Donna Christensen, the CBC Health Braintrust has served as a forceful and principled voice in addressing the issue of health disparities and outcomes in communities across the United States. I want to recognize the Honorable Congresswoman Marcia Fudge, who is in the audience here right now. Whose district is a testament to the important research and medical innovation that is going on across the country, and the type of thought leaders that we have assembled here today are a perfect representation of the folks on the front lines of service in helping to reduce health disparities. This year, under the guidance of Congresswoman Kelly, the Braintrust will continue its vital tradition of legislative advocacy and build on the progress of previous Braintrusts. The theme guiding this year's summit, as well as the CBC's Health Braintrust, is the March Toward Health Equity. Now, we're keeping in mind that 2015 marks 50 years since the transformative Selma March and 30 years since the release of the Heckler Report, which, among other things, led to the creation of Office of Minority Health. So 2015 is a very important year in reflecting and progressing on health disparities. This year, the Health Braintrust seeks to heighten the level of engagement between the CBC and health experts in the community. And in that vein, it will push Congress to commission a greater body of research on the impact of social factors on health. Congresswoman Kelly will work to craft legislation that addresses minority communities' most pressing healthcare challenges while keeping the issue of health equity at the national forefront. And as the CBC vigorously defends the Affordable Care Act, the Braintrust recognizes that the work isn't done and there's still more important work ahead, and looks forward to working in tandem with everyone here today to put a spotlight on the important policy issues and areas of investment that Congress needs to make to help reduce health disparities. As those of us here today prepare for a healthier future, the National Minority Quality Forum would like to recognize leaders who have been in the trenches to help fight and reduce health disparities. And with that, we begin the awards portion of today's luncheon. The 2015 Booker T. Washington Award will be presented by Dr. Maulik Joshi, the Executive Vice President of the American Hospital Association. And with that, I turn to Dr. Joshi.
Thank you very much, Brandon. Good afternoon, everyone. As Brandon said, my name is Maulik Joshi from the American Hospital Association, and I'm absolutely delighted to be able to introduce the winner of the 2015 Booker T. Washington Award, and that's Mr. Tom Zenty from University Hospitals in Cleveland. I'm going to give just a couple minutes because I'd love to just give you a little highlight of Tom and then allow him to come up here. At the American Hospital Association, I've had the privilege to work with Tom over the last 7+ years, and very fortunate to be around him, his leadership, his mentorship, and all that he's done, both locally and nationally. It wouldn't do justice to give all of Tom's bio, but I will highlight a few things. But first of all, the Booker T. Washington Award is a very important recognition. As you all know, this award recognizes an individual or an organization that has made an outstanding contribution to wellness in minority communities and the elimination of healthcare disparities. And there's no one I can think better of than Tom Zenty and what he's done for our nation's healthcare system and what he's done in Northeast Ohio. Again, just a little bit of bio. Tom is the Chief Executive Officer of University Hospitals in Cleveland since 2003. He presides with his team over a very large integrated healthcare system in Northeast Ohio. I could go on, and I know Tom will, but I also want to highlight his work outside of university hospitals. Tom has been on the board of the American Hospital Association, the board and the chairman of the Health Research and Educational Trust, as well as trustee roles in numerous other not-for-profit and publicly traded corporations. Tom is also a fellow of the American College of Healthcare Executives and has been honored both locally and nationally for much of the work that he's done in moving healthcare forward. I think university hospitals' strategic approach to diversity and disparities is really testament to Tom's leadership. You're going to hear some more, but Tom's work, his team's work on supplier diversity, wellness in the communities, cultural competency, and diversity, both in the boardroom, the leadership, and the workforce, is truly impressive, truly impressive. Again, I can give much more, but I just want to end before I introduce Tom with saying he's a gifted leader. Tom is a visionary. Tom is honest. Tom asks the hard questions. Tom does the right thing the right way. Tom is one of those people that you just know gets it. He gets it for everybody. And so with that, I really am just privileged to be up here. There are very few people that I think you could say, you know, is both a colleague, a mentor, and a friend. And Tom is that to anybody that he comes in contact with. So please join me in acknowledging and welcoming Tom Zenty, the winner of the 2015 Booker T. Washington Award.
Well, after all that, that's a pretty big build-up, right? But it is indeed an honor to be here, and I do appreciate, Maulik, your kind words. But I'd also like to thank the American Hospital Association for nominating university hospitals for this recognition. On behalf of the 25,000 employees, our physicians, our volunteers, and everyone with whom we come in contact, this is an extraordinary recognition for the work that we've been doing for quite a number of years. I'd like to, as well, thank Maulik and Rich Umdenstock and Rick Pollock, the leadership of the American Hospital Association, for the work that they consistently do and continually do in order to end disparities and for their focus on diversity and inclusion. The work that they've been involved in over the past decade or so has really made an enormous impact on our field. And when you think about it, there are 5,400 hospitals in the United States who all need to be thinking about diversity, inclusion, and eliminating disparities on a daily basis. They've worked at making this happen. In fact, we do indeed have a committee of the American Hospital Association that leads this endeavor, and they've been working diligently to end disparities around the nation. And most recently, last year, Maulik and Rich and Rick did all the things that they could do in order to make sure that this gets the right form of recognition, and the fact that they give an award as well. The American Hospital Association, in front of 2,000 people at their annual meeting, give a reward and recognition for those organizations that are focused on the importance of diversity and inclusion. I'd like to as well thank Marcia Fudge. You heard about Congresswoman Fudge, who is here with us today. She has been a stalwart in supporting all the work that we do on behalf of the communities that we serve and that she represents. And Congresswoman Fudge, thank you for all that you do on behalf of University Hospitals. Very much appreciated. And I'd like to just make a few remarks about some of the things in which we are involved in, but I'd like you to think about it not in the context of a luncheon presentation, but I'd rather have you think about this in the context of us as colleagues and as friends and as people who can make a difference. So I want to share with you some of the things that we've been able to do that hopefully you can take back and replicate, and frankly, we'd like to hear back from you so that we can replicate the good things that are happening in your organizations all across the nation. Heidi Gartland is here with us today, and Heidi is our leader of our Government Relations and Community Benefits Initiative. She does our community benefits study every year and really works at making a difference in the communities that we serve. So Heidi, thank you for being here as well today. And as we think about our roles as collaborators and as colleagues, I'd like you to just think about this on two dimensions. The first dimension is that we should take today's ceilings and make them tomorrow's floors. The work that we've been involved in has actually made that happen. So if you don't remember anything else from today's brief remarks that I'm going to make, that's one. Let's take today's ceilings and make them tomorrow's floors. And let's also remember that what we're talking about is not a destination. What we're talking about is a journey. And it's like the old adage, if you don't know where you're going, any road will get you there. But as we think about where we need to be, we need to think about where our destination will be. But quite frankly, we will never get there because we always have to find ways to do things better, to do things in a more comprehensive fashion, and to be far more successful with mileposts and guideposts and ways to recognize and celebrate along the way. As Maulik mentioned, our organization was founded back in 1866, is now comprised of about 15 hospitals. We're a regional provider, and we've been founded for frankly, Civil War veterans who are returning who didn't have families and friends to care for them and had war injuries. And from that, we've grown into a major, complex, integrated healthcare delivery system. But I'll just mention a few things. Number one, I won't get into the details because if you wanted to read about the work that we're doing, you can read about it in a study that was published by the Massachusetts Institute of Technology, MIT, as well as the University of Maryland, published something called an anchor mission in our commitment to the community. And we'd be happy to get you that information. It's readily available online, but it talks about what we did going back almost 12 years ago. And the reason why it's still relevant today is the following. About 12 years ago, we decided that if we were going to make the biggest inroads in diversity and inclusion, the first thing that we needed to do was to make sure that our board of directors represents the communities that we serve. And one of the first things that we involved ourselves in was finding the right people to serve on our board. In fact, I just gave a presentation at the American College of Healthcare Executives. And I was asked during the course of that presentation, well, how will I know if an organization values diversity? And I said the easiest thing to do is to go to their website and take a look at their board members and see who's represented. And if they're there, it will make a difference, and if they're not, they won't. The second point that I'll mention is going back now to 2006, we undertook a $1.2 billion campaign, and it was a business-related campaign that was going to be building what ultimately became 2 new hospitals, a number of ambulatory care centers. We brought on a number of physicians, health information technology, electronic medical record, and so on and so forth. But we came to the conclusion that if we were going to do this right, that we needed to think about as an anchor mission, what is it that we should be doing to support the communities that we serve? And first and foremost, we set 3 goals for ourselves. And the 3 goals that we set were as follows. We knew that a $1.2 billion growth commitment needed to represent all the communities that we served. So what we did was we said we're going to devote a minimum of 5% of that spend to female business enterprises, 15% to minority business enterprises, and 80% of that spend would be local. Now, we set those goals on our own. We worked with Senator Sherrod Brown. We worked with Stephanie Tubbs Jones, who unfortunately left us way too young. We worked with the Office of the Mayor, the President of City Council, other elected positions. We've now worked with Congresswoman Fudge, who's helped us through this entire process, and I'm pleased to say that at the conclusion of what we called Vision 2010, this $1.2 billion program, I'm very pleased to say that we set our goals of 5, 15, and 80. 5% female, 15% minority, 80% local spend. And at the conclusion, we ended up with 7% female, 20% minority, and 93% was local spend. So there are far more things I can tell you about the program, but it's a relatively short lunch. I think I've probably been here too long already, but I would encourage you to look to that anchor mission business case. It's now taught at MIT, it's taught at University of Maryland, and it's a great study in how you can work with elected leaders, take your role seriously, understand your mission, and make a difference in people's lives. So in summary, a century after Booker T. Washington established the National Minority Health Month, African American adults are still far more likely than their majority neighbors to die of heart disease or stroke. And if you listen to the presentations immediately before lunch, you know exactly what I'm talking about. Nearly a half century after Martin Luther King addressed the Medical Committee for Human Rights, African Americans are still disproportionately suffering from cancer, high blood pressure, diabetes, and infant mortality. 15 years after our nation agreed to the Healthy People 2010 agenda, we still have much work to do to achieve our goals. And these realities are persistent. However, we can see in gatherings such as this that the determination and inspiration to do these things will indeed make a difference. It's time for all of us to emphasize the power of innovation in the fight against disparities and inequality. History shows us that we need more and different solutions to pervasive challenges. Using our leverage as anchor institutions to foster a more just and inclusive economy is an innovative and civic-minded step toward a more just and inclusive healthcare delivery system. And as we think about the work that still lies ahead of us, every time you're tempted to act in the same way, you decide whether or not you want to be a prisoner of the past or if you want to be a visionary of the future. And I would encourage us to think about the latter and no longer the former. Thank you again for the award. It was a pleasure to be here. Thank you for having me.
Well, obviously they chose wisely. Again, I want to extend our appreciation to Mr. Zenty, and I think we should all give him another round of applause for his hard work. And now to move on to our Biodiversity Health Policy Panel. We have a distinguished mix of policy professionals and thought leaders here to discuss a very timely issue. Most of us are probably in agreement that it's important that biodiverse populations have access to quality care. More frequently than it is admitted, when national health policy is being considered, the implications for America's diverse emerging majority are ignored. This omission by its design promotes disparities by providing care of unequal quality to a diverse community. The purpose of today's conversation is to provide different perspectives that should be heard in this critical conversation. The policies and decisions that we consider affect the health and welfare of many underserved populations. Our panelists today are Dr. Ronald Wyatt, Medical Director of the Division of Healthcare Improvement at the Joint Commission, Dr. Traci Ferguson, Vice President and Medical Director of WellCare Health Plans, Alan Ryan, the Director of U.S. Advocacy and Alliance Development at Sandoz, and Krista Drobac, Executive Director of the Better Medicare Alliance. In the interest of time, I'm going to ask that each panelist please stick to the time constraint that we put on you, which is 8 to 10 minutes, hopefully on the 8 side of things. And with that being said, Dr. Wyatt of the Joint Commission, you have the floor.
My mic is on, you hear me okay? So first let me say thank you to Congresswoman Kelly and her excellent staff, and to Dr. Puckrin and his excellent staff, and to the CBC Braintrust. And thank each of you for sharing lunch with me. I would say that had I known when I talked to Mr. Puckrin a few months back that I would be standing here today, I probably would have said, give me another year. I thought I would probably just meet some people and have lunch. But here we are. I have a lot of slides that obviously I'm not going to make it through. So I will do my best. And let's see. There are some learning objectives. I won't read through those. When we think about the U.S. healthcare system, this statement was made by Martin Luther King some years ago now. But when you read that, what stands out to me is the truth. So what I'm here today for is to share the truth. So I share the truth with you from my heart. As we think about the words you've heard this morning, outcomes, quality, community, service, we need to think about what is the actual truth. and what is happening in the U.S. healthcare system that's ranked among the worst in the world in terms of industrialized countries. So what is the truth? The truth that, from my perspective, and I will say that I speak from my perspective, I have nothing to disclose. I will say that my opinions are mostly mine. I will share a few from the Joint Commission. So the truth is this: we have a system, a healthcare system in the United States that is not just. We have a system that is not trustworthy. We have a system that is not as reliable as it needs to be. We have a system that is in many ways not a moral system when we start to think about equity and disparity. So we talk about, and you've heard a lot this morning about cost and value and you know, what truly do we mean when we talk about equity? I won't describe it again, but Dr. Larry Sanders, my friend, went through the ILM 6 aims. What I will say is, you look at this graphic, is that in my opinion, equity is the queen of all of the ILM 6 aims. Equity is the hinges to the door. It is what holds up equity in healthcare. So I'll share with you a brief story about babies in buckets who were floating down a river and were being saved by people who saw them and were concerned enough to stop their cars and jump in the water to pull the babies out of the water. So as you think about babies in the water, and you've seen this slide from Dr. Egan, you think about what is upstream. So that slide talks about what is upstream when we talk about health equity. So what I'll say to you in the time I have is, upstream is still not enough. When you think about babies in buckets in the water, you can add these labels on this framework to those buckets. Poor outcomes, death, disease and injury, lack of resilience, lack of reliability. We talk about genetic issues, spirituality. You've heard most of that. Those are the buckets in the water. When we go upstream, what we find is what's called the isms. And we can pick one. We'll go into those in a second. So upstream are the isms. But if we go up on the bridge, what is on the bridge? What's on the bridge keeps throwing us off the bridge. That's where, in my opinion, the work has to start. So the stuff on the bridge is what the stuff that I say is killing us. You know, to put it another way, use kind of a DC term, it's the shiggity that keeps killing us. Some of you heard that term. So what kills us? It's our skin color. It's our ethnicity. It's our education, or lack thereof. It's income inequality. It's class. It's if you're disabled. You've heard about geography. So I'll say again, it's zip code, not genetic code. I will say to you again that it's not your genetic code that's killing us. It's the size of the blue jeans that we wear. And you've heard that from Dr. Egan. We weigh too much. We're too obese as a people. These are things that kill us. Sexual preference and orientation. We still can't come to comfortable grips with what that is and what it means and how it contributes to equity and disparity. We think about how we tell people to stop doing some of the things they do, those upstream or midstream things. Stop smoking. This is a graphic from Chicago. I live in Cook County, close to Cook County. You start to think about violence. So then if I say to a person, we want you to stop smoking and eat right and exercise more, and that person says to me, I have a job to go to. I make minimum wage, maybe. I have to take 2 buses and a train, or a train and 2 buses to get to work. When I get home, my concern is not getting shot on the way to my door. So I'm not ready to talk about quitting smoking. I want to talk about not letting the police shoot me. I want to talk about not letting anybody else shoot me or my children when I get from my minimum wage job to my door. Then we can talk about smoking cessation, because that's downstream. So we have to talk about what's real. If I say to a single mother, you need to feed your children healthier foods, not canned foods, not processed foods, she'll say, doctor, look out my window. What do you see? If I have 2 kids, I got to get on a bus and I got to ride across town to get quality produce. Otherwise, I got to go down to the convenience store and use SNAP and get what I can get for my kids. Look outside my door. I don't know when the next bus is coming. The sidewalk is torn up. The street lights are out. Look outside my door. We don't have a playground. Look outside my door. We have teachers that are more concerned about the test scores than my children. Look outside my door, doctor. Tell me what you see. The new Jim Crow. We all know what it is. We have a government, local and county and state and federal, that has decided to exclude people from citizenship. We have to talk about men and women that are incarcerated. I'm from Alabama. There's over 35,000 people in the prisons in the state of Alabama, one of the worst prison systems in the country. Over 16,000 of those people are black men and women. They're no longer citizens. They can't vote. They can't get subsidized housing. They can't get food stamps. They have to check the box. If you check the box, you're 90% certain you won't get the job. What's throwing us off the bridge? Then we have these issues. We say that, well, it's all because of income and education. It's because of lack of access to health care. We have, again, biological and genetic differences. I will say to you, they're all myths. I saw a retinal specialist in Silver Spring, Maryland, here in D.C. area. Did my due diligence. He was one of the best in the city. 10 minutes into his lasering my retina, he said, if you move again, you might go blind. Had nothing to do with my income and education. I had to ask him, doctor, who am I? He looked at my chart. He let out a sigh and said, oh my God, you're a physician. So I said to him, no, I'm a father, I'm a husband, I'm a grandfather, I'm a human being. And plus, you didn't wash your hands before you touched me. Look at what's throwing us off the bridge, not what's in the water. We have to keep working on what's in the water. Access to health care. If I have access to health care, but when the doctor comes in the room, he doesn't look in my face, he doesn't care about me, he walks in backing out, I'm not going to trust him or her. I'm not going to take your medicines. I'm not going to come for your procedure. I'm not going to adhere to your heart failure regimen because I'm not a human being to you. Why should I come back to a person that doesn't care about me? So what does that mean as a human being? We're in states of denial. That's what it means. So we say, well, we're going to have some cultural competency training. We're going to have some cultural sensitivity training. We're going to become more culturally sensible. So what I'll say to the U.S. healthcare system is become more responsible. That means learn how to be more able to respond to what it is as a patient that I need, not what's going to make you feel better. So you may understand my culture from your perspective. That doesn't mean you understand me. I'm an American citizen. I'm from Alabama. I'm from Perry County, which is in the Black Belt, and we eat a certain way. We speak a certain way. Do you know that? Do you understand that? If I'm from the Middle East, I may be from Iraq or Turkey. I may be Shia or Sunni. I may be neither. I eat a certain way. I love a certain way. I dance a certain way. I wear a certain type of clothing. Your cultural competency training will not help you understand that. So as Chinua Achebe who wrote Things Fall Apart, says, if you come to my house, use my gate. Don't come to my house through your gate. What does that mean? In healthcare, I'll translate that to this. Don't hurt me. Don't waste my time. Don't make me wait. Be nice to me. Respect me. Do not hurt me and do not kill me. So at the Joint Commission, I looked at 1,000 episodes of what we call sentinel events last year. A sentinel event means somebody got killed in the hospital. So we figure out why did that happen. So as we think about what it is in healthcare, there's a certain set of truths that we need to start to talk about. And they're not easy to talk about. They make people reach for Tums and Rolaids and squirm in your seat. You see, we have a healthcare system that exists on what we call a pro-white frame. There's implicit bias. Now we call it subconscious bias. I'm not sure there's more conscious than it is subconscious, but the implicit association tests say that a white physician is far more likely to label negative connotation to a black patient. When we do implicit association tests among physicians and the studies that actually support it, what we find is that white physicians more often like white patients over black patients, but you do the same test to black physicians and it's the same. We got to talk about what it is. So I can say, no, I don't see race. If you say that to me, but you still come to me from a position of what I would call unearned privilege, you don't understand what it is. See, because at the end of the day, it's all of us. I grew up in the Black Belt of Alabama with one teaching. We are all simply one thing, human beings. There's one kind of person. So as leaders in your communities and your organizations, we got to talk about what are these things that happen? How is it that a stigmatized group of people are blocked from access to goods and services for decades? So I will say that an act of inaction is an act. If you fail to act, that's a violent act when we talk about healthcare. Whether it's omission, whether it's commission, whether it's supporting structural barriers, they have to be removed. And then if they don't, it becomes person mediated. And I'm sure I'm about out of time. So personal mediation is things like I get poor service. Meaning I go into a store and someone follows me around because I'm a black man. When I meet a white woman walking on the sidewalk, she clutches her purse. If I'm on a train going across town in Boston, there's an open seat on a full bus and no one will take that seat beside me. That's personally mediated. If a physician says to me, Ron, I had no idea you were black, after we had talked on the phone. He went on to say, because you speak almost perfect English. That's personally mediated. It damages us. When we think about institutional racism and the pathogenesis that it creates, it leads to inflammation. It leads, in other words, to heart disease and strokes. It increases your insulin level. All of those good hormones that you need to get through the day are sucked away because you're beat down every day, or what's been called everyday discrimination by David Williams at Harvard, or weathering. If some steps get beat on every day by the rain, what happens to them? They become weathered. And then I say, I'm not going to keep your appointment. I'm not going to talk to you. I'll go to the emergency room because they treat me better there. I can get better treatment there. You won't even give me a Tylenol for my headache because you think I'm a drug seeker. And I got to go. So you can get the slide. This is when I was undergraduate, and there was a question on a senior level biology test. The question said this: what reproduces the fastest? Rabbits, rodents, Negroes, or pangolin? So I protested that, and you can read the article from the Washington Post. It took me 3 attempts to get into medical school after I protested and said, no, that's racist. And you don't deserve to be an instructor at the University of Alabama. So then for us, we internalize racism. Us. Yes, us. Right? When you start to think that a white man's ice is somehow colder. It's not. It's ice. So we got to shed that kind of thinking. We got to bring back hope. We can't be helpless. We have to vote. We have to stay in school. I'm so far over time. So you all are the gardeners, government, industry, healthcare. We got a big garden that we got to tend to. It needs good soil, not old soil. It needs fertilizer. That means if you got to take the resource from someplace else, put it to where you need it the most, because you will get the return on your investment if you're a finance person. We spent over $1 trillion in the last few years on disparity. So we're going to get to that. That's the U.S. that says that in Chicago, in Illinois, there are over 100 different languages. D.C., almost 100 languages. Alabama, 100 languages. Let's get ready for what the world's going to look like. This is what it'll look like when you got insurance. Over 50% will not be white, will not have a college degree, will not be married, will rank their health care somewhere less than good or excellent. We got to look at LGBT and not ignore LGBT. I'm done. Oh, one thing. I'm sorry. I have to. I'm done. But that's my Aunt Molly, who raised me, and I asked her what was life about, and we talk about quality. So I said, I'm going to get married and have children one day. How do you raise children, Aunt Molly? And I equate this to the healthcare system. She said, you got to love them and whip them. But after you whip them, tell them the truth. Tell them why you whipped them in the first place. So as a healthcare system, I love you. The secret to quality is love. Love God, love each other, love your patients, love your community. Then you have quality. If you don't love, you have no quality. That's what Aunt Molly said.
Good afternoon. I wanted to thank Dr. Puckrin, Congresswoman Kelly, for inviting me again to this luncheon. And I wanted to give the perspective from a managed care organization that's focused on government-sponsored health plans. This is sort of the footprint of WellCare. It's a managed care organization sponsored, focused on Medicaid and Medicare Advantage, also with the prescription drug program. And we're in 9 Medicaid states, 15 Medicare Advantage, and 49 of the 50 states for PDP. And one of the things that we as a company have as our mission is to focus on the most vulnerable population. And we've noticed that we can't do it alone as a health plan. We need to partner not only with our providers by providing education, incentives, so that they can do what they do best, and that's take care of our members, but also reaching out and including the social safety net. So those could be the faith-based organizations, whether it's a food bank, and basically looking at what we can do to close the social safety net gaps that we see. There was one, we have a database where we can go by zip code and seeing what is there in the, whether it's they're needing, whether food, child care, that we're able to see what kind of organizations out there. There was one food bank that closed, but by reaching out and looking in the community, we're able to get funding so that we can rebuild that food bank. When CMS requested requested information, one of the studies that was published most recently is from Inovalon, and they've been for the past couple of years looking at information from Medicare Advantage members. So they took a poll of 2.2 million members across over 80 health plans and looked at what are the demographics, looking at those who are dual eligible and non-dual eligible, and seeing what's the difference. And they saw that there was a significant amount of disparities. Looking at the dual eligible, those are eligible both for Medicare and Medicaid, that disability was a significant portion of those that was the original reason for them coming into Medicare. There's a lot of complex medical complications, such as anxiety, dementia, and other behavioral health. And significantly, that 29.3% of the dual eligibles live in impoverished areas. When they looked at different star measures, and for Medicare Advantage, there's a 5-point star system looking to see, measuring the quality of a health plan and outcomes. And when they looked at both some current star measures and some display measures, they saw that they're looking between the dual population, the non-duals, that there are differences that account for 70% of the poor quality scores that you see with the dual population. And then if you account for these differences, which I'll show on the next slide, that you can decrease the gap by 70%. That still leaves about 30% of the sort of factors, whether it's community resources, whether it's other clinical complications or conditions, that there's still 30% that is not accounted for. But the current system doesn't account for many of these differences. And looking at the sort of the top five, living in a poor neighborhood, again an impoverished neighborhood, contributes 18.1% to the difference in gap that you see. Living where you don't have significant physicians, whether it's not just primary care, but the specialist, if you don't have the physician resources. And then looking at renal disease and dementia. And again, if you look at all of these other factors that in this study, they were able to pull information from that's not captured currently in terms of the quality measures, but if you were to account for that, all of these, that you would close the gap between what you see from a dual eligibles in terms of the low income and for the Medicare Advantage by 81.8%. Again, there's still a significant portion, almost 20%, that we're not accounting for even by listing and adding all of these factors in. So as I stated before, CMS, we've, as a company, reached out to the Morehouse School of Medicine with Daniel Dawes and the Health Equity Leadership and Exchange Network, just to give more information to CMS. And again, we provided information to the Inovalon study so that we can get this information to the regulators. And we, in terms of recommendations, there are significant number of measures out there that we believe that should be either risk adjusted or just you account for the socioeconomic and demographic factors. And CMS, when they published their final call letter, did suggest that there was still more information that needed to be done. They wanted more scientific information to see some causality between what's happening outside of, in terms of the patient-physician relationship in terms of any of these socioeconomic factors. And that this is in terms of again, what they stated is that in terms of prematurely trying to cause, or there's some observed association between what's going on in terms of socioeconomic and their outcomes, that they didn't want to mask disparities. And this is in terms of their research. They did recommend in their draft call letter of some of the screenings in terms of the quality measures, whether it's breast cancer screening, colorectal screening, whether it's medication adherence with cholesterol, diabetes, to look at, we understand there may be association instead of triple weighting them. So if you have a poor score, your results are going to even be, it's going to be worse, that they're going to decrease the revised weighting of that to half. Which is a good step, but again, we believe that more needs to be done. And in the final rate notice, CMS stated that, again, more research needed to be performed, that they were not necessarily going to act on what's been published with the Inovalon study, and that they would consider in 2017 some changing to the rate adjustment. Again, the rate adjustment now is for health plans in terms of Medicare Advantage, but there's a natural extension that, in terms of what we're seeing in hospitals with the all-cause readmission, that even if you looking at the adjustment for the readmission rates. They're doing adjustment for their age, for their gender, and for some comorbidities. But even with looking at that, there's still a significant, like 30% difference that they're not accounting for. So I wanted to leave you with this last call to action, that as a health plan that is focused on the low-income Medicare and the Medicaid population, we need to work together. And that's why it's important in terms of our relationship with the Morehouse School of Medicine, with Dr. Puckrin, and with the National Quality Forum, to really get everybody together, whether it's providers, the provider associations, lawmakers, regulators, because there's research out there, just being able to get all that information so that we're making the change together. So that's it. Thank you. That's very good.
Good afternoon. Can you all hear me okay? Yes. So my name is Alan Ryan, and I'm with Sandoz, and you're like, well, Sandoz, who is Sandoz? What is Sandoz? So Sandoz is the second largest generic manufacturer of drugs in the world, and we're the global leader of biosimilar manufacturers outside of the United States. And Alan Ryan, well, who is he? Well, I'm the U.S. head of advocacy and alliance development. And what does that mean? I work with organizations such as NMQF and other, the American Pharmacists Association and other associations on behalf of Sandoz. And so it's a very exciting job. It's just started in January. Other than that, I'm a pharmacist by training. I actually went to school not far from here at Howard University. Yes, where I met my wife, actually, yes, who's still my wife. Yes. And my son is a current sophomore at Howard University. He's in the business school studying actuarial science. So for those of you who might need an employee sometime soon, please see me afterwards. He will be needing a job soon. Why am I here? I'm here to talk briefly about the Biologics Price, Competition, and Innovation Act, which is also known as the BPCIA. The BPCIA. Now, before you go to sleep, okay, I did some quick research on the internet on ways to make a boring topic more interesting. So we'll see how this goes, okay? All right. So another title for this talk could be Improving Patient Access to Biologic Therapies. So what's a biologic? Well, did anyone have bacon or eggs within the past week? That's a biologic. It's a protein. Has anyone in here been vaccinated? Raise your hand if you've been vaccinated. Everybody here has been vaccinated pretty much. Those are biologics that we are vaccinated with. And in 1982, the first biologic medicine, an insulin product, was actually approved for use in the United States. So biologic medicines have been used for decades. And my grandmother actually was very excited at the time when the product came out, because she said it's going to more closely match her own natural insulin rather than using the insulin that she was using before, that she was mentally just not happy with. Now, that product coming out was good, but it was also more expensive. No great surprise. It's a better product. It's more expensive. But as time went on and my grandmother accumulated more medicines, more new medicines that she was on, frankly, managing her drug spend was a challenge that even I was a part of as a pharmacy student. So being able to afford all of your new medicines and continue to add new medicines to your regimen is something that, frankly, even our nation has been challenged with. And that's why there's the Biologics Price, Competition, and Innovation Act. Because prior to that act, any biologic product that was approved, it had a lifetime monopoly. Well, how would that be? Well, there was no pathway by the FDA to approve what would amount to a generic competition or generic copy of a biologic prior to the BPCIA. The BPCIA was in 2010 became law. And so that is where essentially it gave the FDA the authority to create what amounts to generic copies of biologic products for those branded products once they go off patent, right? So essentially you have to have innovation, so there has to be a patent, there has to be a reward for that patent for some defined period of time, and then when that period of time is over, then competition, price competition should come in. So, and we all know how competition impacts prices, correct? We're not going to pay more money for the same thing. So, some might ask, well, where does the innovation part of BPCIA come in? Well, that same grandmother that I talked about earlier, she used to say, necessity is the mother of invention. And I would just say that you could echo that and say, competition is the mother of innovation. It is amazing what happens when patents are expiring. Enacting a law that created that competition is actually going to further innovation in the long run. Now, I would say, I'm proud to say actually, that Sandoz, being the first company to get an approval through this new pathway in March of 2015 of a biologic product, biosimilar, we pioneered that. And it was, let's just say, tooth and nail all the way. Why would it be tooth and nail all the way? Well, not everybody necessarily was happy about new competition. Yes? So I will just end. I'm going to give you some of your time back. Thank you. I will just end on saying, if you want to know more about biosimilars, visit a website called biosimilarscouncil.org. The Generic Pharmaceutical Association has just recently created a separate organization called the Biosimilars Council. And you can visit that website to learn more about biosimilars, which are essentially generic copies of branded biologic products that have gone off patent. And during the Q&A period, I'm hoping to discuss what hurdle, we faced a couple of major hurdles as Sandoz in getting these products to market. And so I'd hope to be able to discuss that during the Q&A period. Thank you for your time.
Good afternoon. I'm Krista Drobac. I'm the Interim Executive Director of the Better Medicare Alliance. I'm so pleased to be here. Thank you for having me. Before I start, I just want to let you know they're announcing the permanent Executive Director of the Alliance tomorrow. I'm just the interim, so I wanted to tell you that because I didn't want you to read it in the news and then think well, who was that up there? So we've been getting this organization off the ground. We're really proud of it. And I just want to tell you, my background is in government affairs. I worked on the Hill. I worked in the Obama administration. And I was never a very big fan of Medicare Advantage early on. I worked on Capitol Hill during the time when we implemented the Part D benefit in Medicare. And we made some changes to Medicare Advantage and we put more money into it. And I thought to myself, why are we putting more money into a program that's essentially for upper class white people? Was kind of the way I thought about it, because in the old days before we had risk adjustment, it really was to the benefit of the health plan to have healthy people in their plan, because there was a capitated arrangement where it was not adjusted based on if you were sick or not. So there was no incentive for health plans to really take on high risks. So that changed in the Medicare Modernization Act, where the same bill that we put in Part D, where now insurance companies have no disincentive at all to treat people that have disease. And today, and now I'm a big believer in Medicare Advantage, because today there are actually a lot of lessons to be learned for Medicare Advantage on how to improve treatment for people with chronic disease. So I'll talk a little bit about how it's also a model, I think, for reducing health disparities. But first, just so you know how different Medicare Advantage is today than when it started, 30% of people in Medicare are enrolled in a Medicare Advantage plan. It's about 18 million people, and 25% of all new people who are aging into Medicare choose Medicare Advantage. Medicare Advantage actually has a higher overall representation of racial and ethnic populations compared to fee-for-service. So there's about 30% racial and ethnic populations in Medicare Advantage compared to only 23% in fee-for-service. Of the Hispanic populations that are enrolled in Medicare, 44% of them are in a Medicare Advantage plan, and 30% of African Americans in Medicare are in a Medicare Advantage plan. Now, because of the way that it's set up, Medicare Advantage plans are incentivized to coordinate care better, to treat chronic disease, to catch things before they become worse, to focus on prevention and screening. And all of that is working. There was a study last year that showed, they looked at HEDIS measures for Medicare Advantage plans, and MA outperformed fee-for-service on breast cancer, diabetes, and cholesterol screening, so outperformed fee-for-service. There's also, if you look at some of the traditional measures of quality of care, there is a difference in preventable hospitalizations for racial and ethnic populations in Medicare Advantage. So this one study, Jazari Basu from ARC, she looked at a couple of different states and found in California, for example, that African Americans were 29% less likely to have a hospitalization than African Americans in fee-for-service. Hispanics, 28% less likely. In Florida, Hispanics were 25% less likely than their counterparts in fee-for-service to have a hospitalization, a preventable hospitalization. African Americans in Florida were 16% less likely than African Americans in fee-for-service to have a hospitalization. So, you know, we all run around in DC talking about preventable hospitalizations. Well, if you look at Medicare Advantage and minority populations in Medicare Advantage, it's serving them well in reducing hospitalizations. In diabetes, which we've talked about a lot, as I'm sure you all know the statistics, 1/4 of Medicare beneficiaries have diabetes, and we're looking at about 15 million people with diabetes in Medicare by 2034. Medicare Advantage is also outperforming fee-for-service on eye exams, glycated hemoglobin testing, LDL cholesterol screening, and neuropathy screening. In fact, one study looked at diabetic patients in 5 states, and there were 9% fewer hospital admissions, 19% fewer hospital days, and 28% fewer readmissions. So, you know, specific diseases we can look at and how Medicare Advantage is doing better. So last I'll say on the racial disparities specifically, just in December, the University of Michigan and Harvard put out a study that found that African American seniors in California and in the West actually had the same level of blood pressure screening as their white counterparts in Medicare Advantage. They didn't start out that way. They started out with a huge disparity between the two of them, but after 5 years of being in Medicare Advantage, there were only 1% difference. So 74% for African Americans in Medicare Advantage and 75% for white Americans in Medicare Advantage. So we're going to be looking into that a little bit further, because what are the reasons for that kind of change in healthcare disparities? The Better Medicare Alliance, we're dedicated to a long-term research agenda that's going to start showing some of these statistics that I've already been talking about, but more about how Medicare Advantage is actually helping treat disease, and we will be doing some specific things around racial and ethnic disparities. So thanks for having me today.
All right, let's give another round of applause for our advocate experts. They did a wonderful job. In the interest of time, I want to move to the Q&A portion, but let's start with you all first. Is there anyone in the audience who has a question? If so, you have microphones on your left and on your right and in the center. So we have one right here.
Yes, I wanted to speak to the issue of the star rating in Medicare Advantage patients. And the last study that you quoted was very interesting in that California was the distance runner with their performance. But everywhere else in the country did very poorly with African Americans. It's undeniable. And so one of the things that I'm very concerned with is that there appears to be a Medicare Advantage program in most zip codes throughout the country. But there also appears to be this dichotomy of some evidence of selection with how the Medicare Advantage recruits their patients, even in the high-cost regions. I'm interested in a couple things. One is with the ACA and the rebasing of the Medicare Advantage rate. I mean, they may go lower than that if they get the 5% above based on high-cost area versus low-cost regions and 5% below, and then dropping down to 2%. And then that's actually tailored for the next ensuing years to somewhere get very close to what the fee-for-service is. And I just want to make one comment, because I think this is really important, is that fee-for-service actually is better in some markets with performance than Medicare Advantage. And my concern is looking at these Medicare Advantage programs and looking at actual selection. And it may be that minorities are pre-selected for in markets where Medicare Advantage performance 3-star ratings are not as good as the 5-star ratings. So I'm just curious about your comments about that piece, because when you look at California, their market is big HMOs, the Kaisers, I mean, they have markets that actually say, well, how can we do a better job at the benchmarks? The benchmarks will change with time, and we're not doing process measures as much anymore. We're doing outcomes, which is ED visits and preventable hospitalizations and costs. Cost is an outcome, not necessarily quality, but cost is an outcome. Where do we go with this whole conundrum of minorities being caught with global statistics that might look inviting, but when you look down at the microscopic level, there's great disparities that exist? And I'm wondering, have any of the panelists thought about this piece? Because and I think you mentioned it earlier, yes, specifically about the star rating.
So,
Dr. Ferguson, did you want to answer that one?
So with the star ratings, I can see in terms of California, they've had a long history of an integrated health system where they own the physicians, hospitals, outpatient. We see in the South, we have in the South Carolina, Georgia, Florida, where we have a large portion of our Medicare Advantage that are sort of dual eligible and high minority presence, that we do see the greater impact of the social determinants of health that are impacting. So it may look like we, in terms of a health plan, we may receive a lower, so again, a star rating, but that's because it's not taking into account, and a lot of the measures are not taking into account. The National Quality Forum is having a trial period of requesting measures and looking ad hoc at current measures to see what we can do in terms of having unadjusted, looking at risk adjustment, and then taking that trial period to see what we can do to have a better balance. But even looking more in terms of the Novolon study, even if you have the same provider with African American and white members, that the care is the same. It's not the care that's being delivered, but it's other things outside. It's the actual member, down to the member level, the African Americans. And again, I think it has a large portion of the economics in terms of what's in the neighborhood. So I think that's one of the reasons why we're here, and we're trying to get people to understand that it's more than just one area is doing okay, but the rest of the area is not, and to make sure we get more people involved and getting the studies and the information so that we can make an informed decision of what to do with the star ratings.
Could I also add to that? Can you hear me? Is this on? Just 2 points on what you brought up. One is that the University of Michigan Harvard study, I think what's so interesting about it is they looked at the same population over 5 years. So that population wasn't necessarily moving around. They were accessing the same kinds of systems in the same states but they found that the disparities rates disappeared over 5 years. So what happened? I think one of the things that the Better Medicare Alliance is really interested in doing more research on is what are some of the best practices that are really working. I think there are already lessons to be learned in some plans that can transfer to other plans, and I think our job is to highlight those. But we really need to do a lot more research to be figuring out what's happening here and what's working. And then the second thing I wanted to mention is you talked about the rebasing in the ACA. I think our research shows, we just did a Milliman study, an actuarial study. There's a good market for actuaries out there. And we found that the cuts are disproportionately affecting low-income populations because what's happening is that out-of-pocket costs are going up for beneficiaries. And one of the, I think the appeals of Medicare Advantage is that you don't have to buy a Medigap plan to go along with your Medicare plan. It's one plan, and the challenge is that as they cut the program, out-of-pocket costs go up. So that impacts beneficiaries, and I would think that it's harder on lower income populations.
Well, thank you very much for your comments. And one last thing, I just want to mention that when we looked at this in terms of minority representation in Medicare Advantage, because it's like a Cadillac that you would like to have because it's little out of pocket and there's not a cap, there's not co-insurance, it includes Medicare B. The only thing it doesn't include is hospice, and we're actually looking at how that can happen. But when you take those duals out of the Medicare Advantage, your D-SNPs, I-SNPs, and when you take them out of that, your minority representation goes down significantly. So that's one thing that I think that we should all be looking at, because when you look at the walkie-talkie Medicare patients, the minorities in that group penetration with regular Medicare Advantage is much lower than what we would have envisioned.
Thank you. I want to jump in here really quick, and my question's for Mr. Ryan. Mr. Ryan, what challenges are you having to implementing, is it BPCIA?
Yes. So, can you hear me? Okay. So it's BPCIA. That's the Biologics Price Competition Innovation Act. And so essentially we are candidly being a company that's looking to be a low-cost provider. We are, let's just say, the competition that we are facing has been very active in doing things that from a sub-legal, but I'm going to say from a regulatory standpoint, to make it difficult to market the product ultimately. And an example would be, there's a lot of discussion going on about the naming of the product. And so to make sure that essentially there's an effort being made to make the name of the product be different than what the name of the branded product is. And what do I mean by that? Every product today, you have Advil and you have Motrin, and they're both named ibuprofen, right? So everyone knows when they go to the store, if they see Motrin and they see Advil and they're both ibuprofen and one is on sale, then you might get the Advil one day, you might get the Motrin the other day, depending on what your budget says. Well, essentially the move is to make it so that our product would be ibuprofen-alpha versus just plain ibuprofen. And that creates a whole set of, let's just say, questions in the minds of the patients and the physicians and everyone that, is this really the same product that the branded product is? And so that's something that we are very actively working to try to address. But to be candid, again, this is one of these things where it's a very intense discussion. So I'm happy to delve more deeply into that with people one-on-one afterwards. That's not something we can get into here, I don't think, but that's something that's an issue right now.
Okay. And Dr. Wyatt, you had the room going, and I'm sorry I took it back from you. You started a movement here. But I have a question for you, and my question is, what is the principal thing that the Joint Commission can do to promote health equity? Moving forward, what are some of those things?
Yeah, so there's my boss and I, Dr. Anna McKee, CMO, we have a slide that says this, we call it 6 dirty words, and it's because the Joint Commission says so. Because in a lot of cases, for an organization to move itself, they will say, we're doing this because the Joint Commission says so. And most often that's not true. But as it relates to health equity, I'll first say that the Joint Commission has not done enough. And for those that don't know, the Joint Commission accredits over 20,000 healthcare organizations in the U.S. and now approaching 1,000 internationally. So the Joint Commission is deemed by CMS to accredit healthcare organizations. Many of them use the deeming in order to get paid by Medicare. So inside the Joint Commission is what we call standards, which really represent the minimum expectation. We would hope that accredited organizations would exceed expectations. There are what's called elements of performance. And when an organization is surveyed, the surveyors look to see if the organization meets those elements of performance. So as it exists now, there's a list of those that's in the slide deck if you share it. What I would say is they don't go far enough. And I say they don't go far enough as it relates to equity because of what you've all heard today. So what we're looking at is, do we need a national patient safety goal that would begin to address equity and disparity? So then that would mean that those over 20,000 accredited organizations would have a set of standards and expectations in order to maintain their accreditation. And in a way, that's bad news, because why should we have to start to look at how do we regulate equity? But I'm afraid that's where we are. And I would go further to say we really don't need any more data or research to know that inequity and inequality exist in organizations. We know that there are hospitals, although the Joint Commission says you should have translation services, they don't have translation services, so that the hospital staff are asking taxi drivers, family members, anyone they can find to help translate a language. So we have to start looking at what is it that we could do and call a national patient safety goal that now says here's a list of things that you must do in order to maintain your accreditation. So as we look at our data, we're beginning to see hospitals that we call top performers. And when we look at top performers, they fit into categories around what's called core measures. But when we start to stratify the data around race and ethnicity, we see disparity that we are beginning to interpret as some level of inequity. So part of my job is to develop national patient safety goals. So the next one up to try to develop will be a national patient safety goal on equity and disparity.
All right, thank you. And it looks like we have one more question, and then we'll close out.
Thank you for your presentations, very enlightening. My name is Uche Uchendu. I'm from Department of Veterans Affairs, Office of Health Equity. And I had a comment with regards to the slide on the what's killing us that you showed earlier. Under the geography, you had rural in parentheses. And I tend to wonder if we say just rural, there are also urban challenges.
Right.
And I wanted to touch that. Just before you answer, I also was going to talk about the regulation and ask, with regards to the Affordable Care Act and the Community Health Needs Assessment requirement, does Joint Commission have anything that is considered under that umbrella? Because that gives the opportunity to see what's really needed in the communities where the hospitals are serving and perhaps areas of opportunity.
Right. So thanks. So since I only had 10 minutes, I couldn't develop those bullet points. So rural is put there as an example, but it goes from rural to urban as well. And now even some suburban issues that are beginning to develop. But absolutely, when we talk about a national patient safety goal again, a strong emphasis is on urban inequities and inequalities. But again, as it relates more to, again, what's called social determinants, but I try not to use that term anymore, because I think it's more important to look at what's driving the social determinants. And certainly living in an urban environment as well as rural are big issues.
Well, thank you again. Thank all of our panelists. And on behalf of the Congressional Black Caucus Health Brain Trust, I want to again thank you all for this insightful discussion that we've had on biodiversity. I wish we had another hour to do this, but I know people have places to go, and I'm hungry. All of you all were eating, but I haven't eaten yet. Dr. Puckram, I want to thank you for being the brain behind this operation. So thank you for all your work. And I would be a fool to not thank my boss, Congresswoman Robin Kelly, for her leadership in taking the helm. You want to stand up, Congresswoman Kelly? for taking the helm of the Congressional Black Caucus Health Brain Trust, and there's no one who's more passionate and heart is more dedicated to serving people in all communities, whether it's urban, suburban, or rural, or some colony that we'll have in the future. Ms. Kelly will be representing all of them to the best of her ability, and the Brain Trust is in good hands. And I want to thank Gretchen Wortman with the National Minority Equality Forum for all her work, because there are so many people who have made this luncheon and made really this summit possible, and it's far too many to name, but she is one of the people that I've leaned on and harassed for the past month, and she has been more than helpful and has put together a great production. So thank you again. And to all of you all, best of luck for the remainder of your conference, and thank you for taking the time to hear us out. Have a great day.